Hello and welcome to today's training, OCD and Strategic Pressure, a strategy for working with treatment-resistant children and adult children living at home with Dr. Jonathan Grayson, PhD. Please note that this is the first training to occur in our OCD series. I am Helen Heyman, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio panel and the dial-in information will be displayed. We will first kindly ask you to mute yourself so that we don't hear any background noise. To mute yourself, you will need to press the gray tab just below the red arrow. You will have the opportunity to submit text questions on today's presenter by typing your questions into the chat panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. We will be sending you the materials after the presentation. If you registered and paid for continuing education credit, you will first need to provide the 4-letter CE code on the webinar evaluation form. You will then need to answer the post-test assessment questions and obtain a score of 80% or above. I would like to now introduce our expert. Jonathan Grayson, PhD, is a licensed psychologist and is director of the Grayson Center and adjunct clinical assistant professor of psychiatry and behavioral sciences at the University of Southern California, where he lectures and supervises residents. Dr. Grayson has been specializing in the treatment of obsessive-compulsive disorders for more than 35 years and is a nationally recognized expert and author of Freedom from Obsessive-Compulsive Disorder, a personalized recovery program for living with uncertainty, a self-help guide for sufferers. In 2010, the International OCD Foundation awarded Dr. Grayson the Patty Perkins Lifetime Achievement Award for his devotion and contributions to the treatment of those with OCD. In October of 2010, the Association of Behavioral and Cognitive Therapies gave his book, Freedom from Obsessive-Compulsive Disorder, the Self-Help Book of Merit Award, recognizing his book as providing sufferers with the highest level of information about the best practices treatment for OCD. Dr. Grayson has presented workshops and written numerous articles and book chapters for both professionals and lay audiences. His work and expertise has been featured in national media. It is a true honor and pleasure to work with Dr. Grayson. I will now pass the screen along to Dr. Grayson.
Can I be heard? I got a message from somebody. Hold on 1 second. Okay, I'm going to assume I can go forward because I'm not getting any weird messages from the moderator. So you notice from the title that this is not the presentation you signed up for. It's a slightly different title because I think that this is really, and I will say this a number of times, the strategic pressure is the treatment of last resort for people. You know, OCD can simultaneously be incredibly devastating, which is so strange because it's also very treatable. And we often say to people that designing a program of exposure and response prevention is relatively easy. However, obtaining compliance is an art, and that's the problem. We can help, but that means convincing the patient. If we can't do that, then basically they're as helpless as they feel. So, for this reason, part of an ideal treatment is convincing the client to accept their goals, right? And it is possible to ram somebody through a treatment. I've seen many people who have come to me from other therapists where they actually never agreed on treatment and failed because of that. I had a young man who came to me. His fear had been that he was worried about the fact that he or his family could die at any time. And he'd gone through what seemed an appropriate ERP. You know, they imagined him dying, his family dying, and he wasn't getting better. So when he came to me, I asked him, do you accept the goals of treatment? And he was like, well, I don't know, what is it? And I said, the goal of treatment is for you to live happily in a world where you or your family can die at any time. I don't want that. And I said, okay, what's the alternative? And he laughed, which was great because, right, there is no alternative. And he said, you know, I said to him, this is great. Now we know why you didn't get better. You never agreed to treatment. You know, so it's not like you have some horrible case of OCD or something that's really terrible about you. You just never agreed to treatment. Then he did something really sad. He refused to accept that goal. He knew there's no other world, but he didn't want to accept the goal of learning to live in it, so he stayed sick. However, there is a difference between never being asked to do treatment, treatment resistance, and treatment refusing. So I'm going to be breaking this presentation into 4 parts. Who can benefit from strategic pressure? Cautions and caveats in using strategic pressure. Designing a program with pressure. And the subtext there speaks for itself. And then we'll do some case examples. Who's strategic pressure for? Frankly, what is always really upsetting to me is when I see somebody who's 30 years old, housebound for years, and that is nothing compared to my terror when I see a 12 to 13-year-old housebound who stopped functioning, right? Because I know that with every passing year, that kid is more likely to become that 30-year-old. So a few years ago, actually maybe 20 or 30 years ago, I'm not sure, a psychologist friend of mine, Gibbon, and I were obsessing about this problem. What do we do about these kids and adult children who are stuck and aren't getting any better? Now, obviously, the first thing you do with any client is we try to persuade them and talk them into that. But that's already been tried and failed. You know, we don't really want to send them back and say, well, you're not ready for treatment. Wait till you're ready, because some of them don't get ready. In my center, I have a free support group for OCD, and so often what I'll do with people who are scared to do treatment is come to the support group, and that way they get to save on insurance money, they don't waste money on sessions, and hopefully they look at the people who are doing well, and sorry, the phone there. Hopefully they're going to see who's doing well and start to imitate. But of course, not everyone accepts that, and it's not for children. So, strategic pressure would be for people who are definitely refusing treatment under any circumstance. Now, inpatient is often an option, right? You know, we certainly with minors we can stick them here even if they don't want to. Adult children would have to agree. However, hospitals can't force somebody to engage in treatment, and we've had plenty of people, unfortunately, successfully resist inpatient treatment. Another problem, of course, is even if treatment does reasonably well, once they come home, if the parents haven't been involved, a lot of people will relapse. So the idea of forcing someone to do treatment, literally, hit Lee and I as like a kind of reasonable thing to do. I mean, when you have a drug addict child or drug addict, we often try to force treatment on them. And we could not think of another alternative. I mean, some people talk about tough love, but you know what? It's kind of a cheap thing to say, because we're talking about parents who are not going to be throwing this person out of the house because they've obviously enabled them. And also, you know, just to say toss them out is really pretty simple. You would actually need some kind of protocol, and I'm not sure what kind of protocols there are. So Lee and I designed strategic pressure for the right client. And I want to be clear, treatment of last resort. Everything else has failed, and we're trying to tell people the alternative is this or lifelong dysfunction. Our first client, we kind of had planned all this out and we were just waiting for somebody to come, was a young boy who was 12 who came to us directly from a hospital. Now, I don't mean a mental hospital, he came from a regular hospital. He had an extreme fear of having feces in his body. So he had done such intense pushing so constantly it damaged his rectum. He would refuse to eat, so he looked pretty sickly. And basically he'd been in the hospital for medical problems. He came directly out of the hospital, nothing had been done for his OCD. So he seemed to us like an ideal person to start with, and I'll be coming back to him later. Someone has a dog I'm hearing. I don't know if everybody can hear that. So, the minute before, we talked about adult children living at home. And that's really critical, because it turns out that people living at home don't have any rights. So if the adult child is paying rent, I can't do strategic pressure because they actually have some rights. So it's basically, I have a person who's living at home, either adult or regular child, not paying rent, and then parents can now do things that I as a therapist can't do. And I'm probably making this sound scary or more extreme than it really is. Let me start with the goals of treatment, right? You know, we want to have symptom reduction. We want to have a sufferer who's a willing participant in a plan, undergoing the pain and treatment to free themselves from OCD. All right, normally treatment progresses pretty quickly, right? A few weeks to less than a year. However, those are the goals of normal treatment. They are not the goals of strategic pressure. So, strategic pressure, again, we're going to have to find a way to force them into treatment. And again, I don't want to just send somebody away. I mean, often I would send somebody away from treatment if they're not ready, like that young man I mentioned in the beginning, because I don't want somebody to go through treatment who's not ready, and then it fails, and then they say treatment doesn't work. Right? This is a different group. They're helpless, housebound, and nothing has worked, and we have some hold over them. Okay, let's see. I'm sorry, I'm a little out of phase with my slides. Okay, so let me talk about the treatment goals of strategic pressure, right? Ultimately, the primary goal is to get the sufferer to choose the ideal treatment. That might not be achievable, so we have the secondary goal. Improve the sufferer's levels of functioning, and improve the family's level of functioning so that they can cope with the OCD. And because the sufferer is unwilling, the parents are now the patient. So there are 4 phases of treatment I'd like to just talk about, and I'll kind of repeat this again. The family is the patient. So initial sessions are going to take place with the parents only, and according to guidelines I'll be presenting below. And the treatment will be implemented regardless of what the patient says. I'm sorry, my notes are looking a little weird, so I'm a little out of phase and I don't understand why. Okay. So the second phase, the family is the patient. The sufferer is joined in the family sessions but still refusing treatment. And the family is going to come to sessions. I mean, they will allow the person to come to sessions to have some influence. The third option, the third phase, is the sufferer decides they want to have their own therapist. And we'll permit that. And we're having 2 therapists. So we have kind of a good cop, bad cop situation. And for some reason, whenever I did 3, I was always the bad cop. In the 4th phase, if we get there, the sufferer is actively engaged in treatment. So here's the problem. How do you get someone who's too frightened to work on change to the point where they're willing to work on that? You know, because again, not all refusals are the same. I mean, we do have people who have treatment resistance. They're coming, they really want to work on treatment, but they're afraid to. We have some people who have a problem that we describe as merged. And that's when you have comorbid problems that are interfering with the OCD, and that would be another talk. But then we have these people who are housebound. And, you know, so we want to use the idea of like, well, can we wait till they hit rock bottom, the point where they feel they have no choice? Great, these are people who seem to have no rock bottom. So what are we going to do? We're going to try to find a way to create and to make a rock bottom for them. And you know, so we need to structure treatment so as to give them no choice, but at the same time make it gradual enough to make initial change within reach. So what is our leverage? Because we're talking about people that have given up everything, right? They're at home, they're often just literally isolated, spending most of the day doing nothing. So what's our possible leverage? How are we going to get them to do anything? And it turns out that there is one thing that we have that has power over them, and that is their OCD. Okay? We're going to present them with forced choice decisions to make some change, or the families can implement an exposure that's worse. Now, I'm going to give an example that's a little more extreme than what we do, but just so you get the idea, it's kind of like, I would like you to touch the wall, and if you don't touch the wall, we're going to take a towel that we rubbed on the toilet seat and contaminate all your possessions. Obviously, we're not going to quite do it that way, but you can see that the person's now confronted with the one thing that motivates them, their OCD. And so the decisions are always, they're going to do something, we're going to do something worse, and it pressures them to move forward. And we also going to set deadlines for removal of selected enabling behaviors. That is, the things that the parents are doing to enable the child, we're not removing those things all at once. We're going to leave them in, but there is going to be a point in time when they know that all these things are going to stop. So as the sufferer learns that these forced choices are going to be implemented, the future deadlines become real and much more motivating. So the very first step of strategic pressure. I mean, I'm going to have the parents in session. I'm going to describe a lot of what I'm telling you today earlier. But the very first thing they're going to do, they're going to go home, tell the treatment refuser that they're going to be using strategic pressure. And when asked what that means, they're going to say they don't know. So we're making it pretty mysterious, and this has two purposes. It informs and prepares the treatment refuser that something new is going to happen. Doesn't give them any details to argue with, and it doesn't, because it's not actually implementing a change, it's actually a very gradual and gentle thing. Now, of course, we've done it with this kind of scary, they don't even get to know what it is. And that has to do with the second goal. The parents basically have been terrible at setting limits. So this is a baby step for them, to go home and just say what I'm telling them to say without arguing, okay? Because they're used to getting in these arguments with the person, and that just doesn't work. And, you know, in fact, it reminds me of something that I had with my son. My wife and I, we were really wonderfully enlightened parents, and so we would always explain to Josh why he could or couldn't do something. In our minds, we're giving him the explanation. In Josh's mind, we were giving him his points that he needed to argue. And I have to tell you that when you have two really verbal parents, you create a verbal monster. His wife will agree that when he starts to argue, it is pretty scary. Anyway, so what would happen is we would give him our reasons, he would argue, and he would really give it his whole heart. He was so into it. And when he realized he wasn't going to get it, he would really freak out. So I developed a special system to deal with this that worked really well. I would say, you can't do X or Y, and he'd ask why, and I'd look at him and go, because I'm an asshole. And Josh hated that, because he couldn't argue with it, and he tried. I used to have respect for you, now I don't have any respect for you. It's like, I'm sorry you feel that way, but this is what we're doing. Now, he'd be upset, but he would never get to that point where he would really crack up. So we have these parents, and they're presenting this idea to them, and the person's going to want to know what it is so they can argue about it. And we're basically to tell them what to say. We don't know. He hasn't told us yet. I'm sorry you feel that way, but this is what we have to do. They are not allowed to give any other explanation, and they're not even supposed to go into you're really sick and all, and you know you have these problems, and this is why we're doing it, because that's just another argument where the person's going to say, no, I have it under control, and blah blah blah. So we're teaching them how to really avoid arguments. And again, your job is to go through this with them in session, to role play it till they get it right. I'm having such fun with these slides today. Now, it may also be that the person has read about strategic pressure online, and if they have read about strategic pressure and they want to then talk to the parents, accuse the parents of what it is, again, the parents are, he hasn't told us about it, so we don't really know. Now, we're going to actually talk about starting strategic pressure. Right now, every week we're going to send the parents home with a contract for the child or adult child to see. And the contract is going to have to include exactly what is being requested of the child and exactly what the consequence will be. And I can just read you this is from the child, and it'll become clear, but some of what her consequences and demands were. There could be nothing on the kitchen table at any time except when the family is eating dinner. There can be no trash on the floor at any time. All trash goes directly into the trash can. Missing trash cannot happen. Parents will, and the consequence is parents will remove anything left on the table. If trash is on the floor, Dad will use the shop vac to clean all the trash on the person's protected area. The shop vac was something that was really dirty. So we had somebody who had stuff on the table. It was a very protected area, and we were getting them to clear off the table. And mind you, the table was like their table. So having it cleared off was a big deal. Having dinner eaten there was a big deal. And they would throw trash on the floor because they didn't want to deal with it. So we were gradually forcing them to keep their area a little clean. The very first, this or that, and it's kind of nice. One of my clients, they referred to the treatment as this or that. The very first thing you do needs to be insignificant. The exposure has to be so minor that the sufferer is completely willing to do it, even in a kind of belligerent way. It's like, yeah, I'll do that. I don't care. Fine. And the consequence has to be so insignificant that the sufferer doesn't care. I'm not doing this. I don't care if you do this to me. And there's a reason for that. We're trying to help them. Well, what I have to explain to the parents is that it doesn't matter what happens on this occasion in terms of whether the sufferer follows through or doesn't follow through. Okay? Doesn't matter. All that matters is that the system has started. So it's a success if the parents do their part or if the child does their part. We're starting for it to be so insignificant for a few reasons. First, this kid has been completely enabled. They're used to getting their entire way. So if we do something major, we're going to start World War III and they're going to freak out. So we don't want them to do that. They're beginning to learn that when their parents come home from a session, that they're going to do whatever that crazy Grayson says. And over time, treatment's going to ramp up. If they follow through and they do the exposure, we're going to ask for more next time. If they don't do the exposure, the consequence will increase. So one way or another, the system is gradually ramping up exposure. We have our prime rule for parents. You have to do exactly what I tell you with no improvising. You can do more by adding other exposures, and you can't do less. At some point during treatment, and again, I warn parents, the sufferer is going to find a loophole in our contract, and they're going to take advantage of it, and they're going to feel like I'm really getting over on everyone. And parents are initially going to be upset if you don't warn them. And I said, no, this is great when they find a loophole. It's fantastic. Why is it great when they find a loophole? It means that they bought into the system. They are now depending and trusting on these contracts. And that is the reason for this prime rule. Because as long as the parents are not doing more than I say, they can trust the contract. And of course, if the parents do less than I say, the contract has no power. And as for the loophole, it's irrelevant, right? Because we will correct it the next session. So we're going to basically be ramping up both exposures and severity of what's occurring. And we're also going to attempt to increase the functioning of the sufferer. So we're going to be asking them to be doing more social things if that's their problem. We're going to try to get them out into the world, taking care of themselves in other ways. So we're getting somebody who's basically literally not functioning and getting them to function again. Treatment will be incredibly slow. This could be, you know, we're talking 1 or 2 years, and in the beginning it is painful how slowly it is. You know, I'm talking about starting with something insignificant. You know, it may be that we have found something, you know, very safe, and we want them just to touch it with their finger initially. We're just trying to get them to touch something with their finger. We're not doing regular exposure where we have all kinds of rules to make sure the exposure is pervasive. We're going for something really little, touch with their finger, and to expand from that little island and make it big enough that it's real treatment, it's going to take time. In that second phase, you know, where they start coming to sessions, because basically once we start strategic pressure, the sufferer is not allowed to come to sessions. Now we have 2 situations. One, where we don't let them come, or 2, they don't want to come anyway. But we're beginning to give pressure for them to want to come to sessions, because parents come home and they keep bringing all this horrible stuff, and the thing is, you're only allowed to work on the goals in session. So once it's home, there's no negotiating. So in an effort to have some control, eventually they want to come to the session. And when they come to the session, I'm there. They're not really going to get as much input as they would like. You know, they learn very quickly that, you know, they're going to have to do something significant. If they don't like a goal that I've suggested, it's up to them to come up with something that we feel different, you know, is better. Now during this phase, they kind of get into it more, and they kind of reach a point where they actually may want their own, want their therapist. And there are kind of 2 ways we do this. One is we actually have 2 therapists, right? One therapist is at, the other therapist is the person who's been imposing strategic pressure. And we have a nice good cop, bad cop situation, because their personal therapist will say something like, well, you know, what are you going to do this week? They'll make some suggestions like, well, you know, Grace doesn't want to accept that. We have to do better than that. So in a sneaky way, their therapist is kindly pressuring them to pick something that's going to work when they come to the negotiation, because these 2 sessions would happen simultaneously. Then we all get together to work it out. Now, we can't always have 2 therapists. Recently, I have not had that situation where I can have another therapist. And so when you do it by yourself, that second phase where they've decided to come kind of gradually shifts and changes to that third phase where they start to have more input. And basically, because you're such a pain in the neck and so rigid, they learn to make better deals with you to get their way. And they go from maybe potentially really hating your guts to kind of almost like you. And then if you're really lucky, we get to that final stage where they're fully collaborating with treatment. Now, there's some cautions and caveats to this. And special.
Yeah. Sorry.
Okay. So, the person's in an emergency situation, right? They are not functioning. They've been at home for 30 years, or we want to make sure that doesn't happen. So we have to help the parents keep focus as to what is most important. So I want them to learn to ignore verbal insults and challenges. I don't care if their kid says, fuck you, I'm not doing this. I want them to ignore it. And again, you have to work with parents to ignore all that, because the most important thing is the contract and getting the person to follow through with whatever we're trying to impose on them. Now, so no bargaining out of sessions, no improvising, no shifting from the OCD goals, right? And the family needs to be prepared for how slow and difficult it is. It is very disheartening for families initially how slow this is moving. However, of course, there are some things that have to have, need attention. No violence, right? Any kind of hitting, destruction of a property, If they don't come under control, I want the parent, if they don't come quickly under control, and if they stop, I want the parents to do an involuntary hospitalization because they're violent. Parents really hate this idea. And again, unfortunately, right, this hospitalization is not going to be really therapeutic from the point of view their OCD is going to be helped, but it will be an aversive experience, and it will help the child to know this can happen. And I had a treatment fail because a parent wouldn't do this. There was a young man, and he was completely happy to smash a plasma TV and anything else really expensive in the house. And I said to the father, I need you to hospitalize him when this happens next time. And the father's like, I don't want to do that. Can't we do it some other way? We'll just do it until he does that. It made no sense, because the child was going to do that, and the parents at a certain level of smashing were going to give in, because that was his method. He would literally destroy things until they backed down. I have a saying for married couples, if one person's having major problems, that in an argument, the crazy person always wins. Well, in this case, if they weren't going to hospitalize, he could break everything down. So the treatment failed. Obviously, if the patient becomes really suicidal, then we have to protect them. So I don't want any kind of self-injury or suicidal behavior. Again, we will hospitalize or have the parents watch very closely. I do want to say that to date, this has not ever happened. How do sufferers feel about strategic pressure? Well, initially, they really hate it. It's stupid. One guy would, a young man, he would tantrum frequently, complain, say he hated it. At the very end, he kind of said, you know what, it was helpful. It was like a man helping me across the street. It's going to be really uncomfortable for parents, right? Because, if you're an enabling parent, a lot of times you feel like you're being horribly cruel, because a lot of times when you're imposing this, the person will clearly be suffering. They will be really anxious. You're forcing this exposure on them, and they're upset, and they're going to be crying and all this terrible thing, and you're doing it anyway. And so you're going to need to help encourage and motivate the parents, kind of remind them they're doing this out of love. Remind them this could be your whole child's life. Do you want them to have anything than this? So as much as bad as you feel now, you've tried everything else. So we're going to really need to help working them. I do think one caveat, which is not a problem in the group that I'm speaking to now, I do not think this is something that a parent can do without professional help. I think the relationship is too messed up, and parents have a tendency to, again, either push too hard or not hard enough. So I want to take some time to talk about some case examples. I do not have outcome data. So in a very general way, let me just say that we have some cases who made it to what we consider that full recovery, where that is they became a treatment partner and the rest of the day. We have a number of cases where there was incredibly significant improvement, but the person still obviously had OCD and was holding on to symptoms and was not as free as they could be. Most of our failures have really been the parents. That is, the parents would refuse to engage in the process or refuse to follow the instructions as we laid them out, and so everything would fall apart. So let me just talk about a few cases to give you some background of what it kind of sounds like. So the very first case I talked about, our very first case of strategic pressure that I did with Lee Fitzgibbons, this young man came to the session. Again, he came directly out of the hospital because of the medical problems that had ensued from forcing himself to poop so much that he had damaged his rectum, and he was kind of starved. He looked really bad. And in his very first session, he comes and we're talking to him, and he said he wanted to go to the bathroom because that's what he does. And so we kind of made a brief, quick contract with him. We gave him a certain time limit, and he did it. That was good. He came back in 5 minutes, and then we're talking a little bit more, and then he wanted to go to the bathroom again, and we made another contract, and this time he wasn't following through. So here we are, we're the strategic pressure experts, and we want to do this treatment where we have it all planned out, and he's already just broken an agreement, so we have to follow through. So I get to be the lucky one since it's a boy. So me and the father basically go in the bathroom while he's on the toilet, and he was not a happy camper, right? Because it is a horribly humiliating thing. But we go in there and we basically, we don't drag him out, but our presence and humiliation and our nagging, he comes out. We try to start doing the session, however, he's now pretty belligerent. So Lee and the parents go to another room, and I'm left with this kid who does not like me and does not want to be in the room with me. In fact, I have to block him from running out of the room. I'm waiting while Lee is explaining strategic pressure. Thank God the parents finally come back. So for a long time, I was the most hated thing he could think of. And he was seeing Lee, and well, actually, no, he wasn't seeing Lee initially. I was working with the parents. Eventually, he started seeing Lee. But basically, he began to buy into the system. He was the one who said, it's like a man helping me across the street. And as he got better, I became not so bad. Another young man kind of illustrates that inpatient doesn't necessarily work. He was a 19-year-old, and he had been at McLean's OCD program, the inpatient program. And he failed there. He basically refused to do treatment there. He came home, he was immediately housebound, he couldn't do anything, and his rules were incredibly strict. Nothing could be touched. He did not like to literally be breathed upon from 5 feet away. That was a calamity. And so the whole house was controlled by him. Very restricted eating. So he was in very bad shape. And the very first time we did a minor strategic pressure, I think he had to touch a drawer with a finger, or the parents touched a wall, literally a wall in the hallway, not even his bedroom. And his response to that was to sit in a chair for 3 days. However, we decided that for the next session I would come to the house, and as it came close to me coming, he got out of the chair. Now, his treatment was very slow, and again, you know, think a hallway being touched by his parents was very bad. I began doing treatment at his home, where we would have what he would have to do, and again, starting really small, touch a drawer in the kitchen. We're going to touch something. So I'm there one day, and he didn't do whatever it was, so I touch the wall in the hallway, and his response was to call the police. I'm like, great, I'm in the house alone with a 19-year-old who's calling the police on me. I call the mom to explain the situation. The police come, and this is kind of sad, but worked for me. The police are outside. Well, he's afraid to go outside. So I go outside, and I guess it's equally scary because I'm telling the police about the problem. He's the one who called, and they're believing me. You know, they're more, is he suicidal? You know, is he homicidal? No, no, he's fine. The police come in the house, and we get the mom on the phone, and she's explaining everything to them. You know, and they're listening and getting it, and then they talk to him where he's going to explain his side. And he explains in great indignation that he touched the wall. The police were not really impressed with that. So this young man who was housebound and could do nothing, at the end of treatment, he finished, well, during treatment, but, you know, he finished college, he got a job, he's married, children, and he's still working, and this was about 20 years. Now, he did not see me and continue treatment. He has a load of obsessive compulsive behaviors. But married, working with children is a far cry from being housebound forever. And the last one I want to tell you about is this little girl that I recently worked with. When I came to her for 2 years, she'd been living in a 3x6 area in the kitchen. It was bounded by 2 walls and a kitchen table that was her blockade, and she had kind of a blockade of stuff in front of her. And when I say lived in that area, she basically had not left it. So there were periodic trips to the bathroom. They were very strange, and I'm going to spare you the details. When she would have her period, she didn't really like to use tampons or pads, so there was a lot of underwear that would get thrown away. In fact, clothing was regularly thrown away. There was a lot of trash all around the corner. So she had like a little kind of chair that she slept and laid in, a lot of plastic. She had a lot of white clean things, very limited diet. And so when she came to treatment, or let's say when treatment came to her, I spent 1 month trying to convince her to do treatment. When I first came to the house, she'd been told the night before, and, her parents thought that she would completely freak out. She was partially freaked out. She was unhappy that I was there and didn't want me to go further than the front door, so we held the session from the front door. I gradually worked my way closer over sessions, but it was clear after a month and a half of this, okay, this kid is not doing anything, so we began strategic pressure with her. And again, really slowly. She had to take 2 pieces of trash, and trash, this is her own trash that she's touched, and she had to pick them up from the floor and throw them in a trash can that was within throwing distance. And if she wouldn't do that, the strategic pressure contract, so on a chair 10 feet away from her, was going to be moved a foot closer. And so treatment gradually encroached in her space. It was very, very slow. She still spent months in that corner. I mean, Mom became very discouraged, but I'd point out the little bits of progress we had, because there was a kitchen table next to her on one side that nobody was allowed to eat on. And she progressed, we began to encroach in the space, because when she wouldn't do something, we had to take that kitchen table and began to put things on it and move it closer to her. Also, the kitchen table was one of her boundaries. You began to, when she wouldn't do things, the kitchen table would move a few inches away, so her area was expanding and kind of the outside was gradually coming in. It's a very slow treatment. I thought I would just read some of her plan from why she was being treated. And this is a point where we're not only doing exposure, but we're trying to get her to function better. So we got to the point where that table was now cleared off, and the family could eat dinner at the table. And basically, so if she complained about them eating dinner, then we would remove her phone for 2 hours. And again, her phone was her only contact. We'd gotten the floor clean. It was a very gradual process. We had to a period where she had to pick 5 pieces of trash up from the floor, or we were going to come in and basically clean it all out. So she would do 5 pieces, and we negotiate up to 7. Gradually, finally had the floor clean. And so in 1 week the plan included she had to wet swiffer the floor in her area once a week on Sunday, and on other days once a week she had to do it, use a dustpan on the floor. And if she didn't do that, Dad was going to vacuum and mop the floor. And if she resists, her area was going to be sprayed with the spray bottle. One of the worst exposures. Basically, it was interesting. She had a contamination problem, and things got contaminated by her idea of them. So basically, I quickly became literally the worst contaminant in the world. So we had a spray bottle filled with water, and in the spray bottle was one of my hairs and one of my fingernails. So this spray bottle was like Ebola to her. So, and at one point we would spray my business cards and put them on the table, but the ultimate would be like, we're going to spray your area. So that would get her to do a lot of things. So she had to clean the floor every day during this period. Again, because she'd been in this corner, when Mom would ask her, and it had to be exactly when Mom asked, she was going to go to the bathroom. That is literally just walk there, turn the light on with an object, like a fork, pull 3 pieces of toilet paper, put them in the toilet, and flush them. Then we had to walk to the front door. It was a blue piece of tape and just walk there. Then return to the bathroom and turn the bathroom light off with protection and leave the bathroom. And this was separate from the times when we could actually get her to use the bathroom. So this was kind of pre-behavior to get her to use the toilet eventually. There are about, at this point, and I will spare you, I'm just looking. Yeah, this goes on to 15 other things where we have this or that's. This took 2 years, because it took a long time to get her out of the corner, a long time to walk around the house. She had her bedroom that was a shrine. No one was allowed in it. There was a little stuffed animal that had to be protected at all costs. And gradually over 2 years. She went in the room day and day because she was too contaminated to go into her own bedroom. By the end of treatment, I was allowed in that room. And at the end, and actually at this point in time, she's been out of the corner, sleeping in her bed now for about 9 months. She's back in school, and she's basically relatively free of OCD. And I don't know how many of you have come to the OCD conference. We do a really wonderful thing. If you haven't been, I recommend you go. And I do this one thing called Road to Recovery, where I take 200 to 300 people, literally, out on the town, where we walk around doing all kinds of horrible exposures. This is preceded by I give people a 15-minute motivational talk in the beginning. And this year, she told her story at the motivational talk. Now, it's kind of cute. The way she told her story, she had kind of changed it into a mythological fantasy where she's a princess trapped in a cave. And in that story, her description of me is an old man, not too good looking and not too smart. She does have a sense of humor. And I went from being absolutely hated in the beginning to, we kind of had an interesting, she would claim to hate me, but it was clear she would be kind of enjoying some of the back and forth too. I am now okay. Now, of course, that's not really the goal, although I always think it really all should be about me. But that aside, so she's basically free at this point in time. And, you know, obviously the parents are really happy. It was very difficult for the mom. This was a very enabling mom who felt it was cruel. And the first 3 months where things were going so painfully slow, she felt horrible. When the little girl finally left that corner and started walking around, at that point, she began to really feel like, okay, treatment is actually working, and she then came on board and was doing much better at not enabling. So with that in mind, I'm ready for questions, and for all of those that you wanted that learning code, there it is, TDEI.
Thank you so much, Dr. Grayson, for this excellent presentation and for presenting your cases and your experience with different patients. We have a first question, and this is namely, if you have a client who refuses treatment, do you need to find another therapist to do the strategic pressure with the parents as the clients so that you can eventually re-engage with the client in phase 2 or 3 as the client's therapist? Or can you work with the client and then work with the parents, and when the client is ready to re-engage? So in other words,
I have the question. Yeah, I have it, and it's a great question. And the only bad thing about the question is I clearly didn't explain that well enough. So, yes, I mean, I'm going to try to start with the client. Now, often with these clients, they may come in with the parents first anyway because it's so hard to get them even into treatment. But if it's somebody who I have started with, and this is going to happen pretty early on because it's going to be somebody, it's not going to be somebody who I'm working with and they're gradually getting worse. They're probably coming in and they're extremely bad, and it's amazing they even came to the session. So yes, I'm going to try that month or so of trying to talk them into treatment and see can we get them to do anything, and if that fails and I decide to do strategic pressure, the idea of getting in another therapist to do the strategic pressure is a great idea, except for this one minor difficulty, which is the odds of finding, first of all, another therapist who's really good with OCD and familiar with this are really slim. So if you're at a center and a bunch of you are working this together, you could pull that. So, right, normally, yeah, in a sense, I'm the one basically throwing the kid out and I'm doing the strategic pressure. Now, if I had another therapist I could do this with, said when Lee was, when I was working with Lee, we would always kind of shift off and the other person would get the parents to do the strategic pressure. But yes, you can do it, and I kind of throw them out. And it's going to be a long time before they get to work their way back to being my client. And the little girl I was telling you about, essentially, she started out as my client. That failed. Then I started working with the parents. And then, although I did a lot of the treatment in the home, the strategic pressure was happening when I wasn't there, where there were 2 sessions a week, and I was part of the exposure. So it was kind of a little bit of an odd situation, because normally it would have been the parents imposing everything until she came back, and we gradually reintegrate into therapy. And I hope that answers it coherently.
Thank you very much, Dr. Grayson. We have a second question from the floor. Are there limitations to strategic pressure for autistic spectrum patients? So I repeat, are there limitations to SP for autistic spectrum patients?
Well, I mean, there are two issues, at least. Okay, when you talk about spectrum patients, I am assuming we're talking high-functioning kids or Asperger's. And I say that because I've never done it with somebody low-functioning, and I think I would really need to think careful about imposing that. I think anytime I'm working with a kid on the spectrum, I have to take into account when I'm working with a kid on the spectrum, OCD treatment can look a little different depending on that kid. I mean, right, I have to take into account, and the only reason I'm pausing is I think it could be done, but that assumes that you know how to work with a kid on the spectrum who has OCD, because even though I'm going to do ERP, I'm making major modifications to account for the Asperger's or high-functioning autism. So I think it could be done, but that presumes that you know what you're doing, and assume the person asking the question knows how to treat the spectrum problems as well as the OCD.
Thank you very much. We have two more questions that just came in. Here's the third question. Since this therapy puts the parents at the center of TX, how do you work with parents who themselves are TX resistant, such as excuses about being too busy, low distress tolerance, or even a secondary gain? So how do you deal with parents who themselves are having...
No, I don't want to be glib, but that would be when treatment fails. If they won't follow the treatment protocol, it won't work. And I mean, I think we'd quickly come to a point where it's like, this is the way it needs to be. If you're not doing this, it's not going to work. In a sense, I'm not really with my clients so rigid and saying do this or else. Generally, I'm happy to argue with them, about treatment, and I want treatment to make sense to clients. I always say, don't listen to anything I say unless it makes sense to you. I'd rather argue about it until you're convinced. So with these parents, I'm basically not going to do strategic pressure if they're not convinced or compliant. It'll be a waste of their money. So I'm not going to give up on the client if the parents are going to work with me. If they're not going to work with me, then that's it. And I've had parents who have, there are those cases where it's like, we can't do this, if you're ready, come back some other time.
Thank you very much. Our next question, we still have a couple. Can strategic pressure be applied to sufferers who refuse prescribed medicines?
Yep. I mean, in 2 of the 3 cases I described, the medicines were part of strategic pressure. And for the medicines, normally for most things, we're kind of ramping up very slowly on the consequences. Generally for the medicines, we tried to make it a lot more dire because, when the kid is obviously depressed and bouncing off the walls with anxiety, it's critical. The little girl I told you about, we did force her to take medicine under those circumstances, and actually there was, obviously she didn't jump to being improved, but treatment began to move a little quicker, when we got her on meds and they began to work. So yes, we certainly would do that. And again, it's one of those things, parents are the patients, so they're allowed to do this kind of thing. I'm not.
Thank you. Here's a further question. How does this strategic pressure work with Tourettic OCD, which is strong urges to touch, tap, rub, not quite Tourette's?
Great question. I don't know. Tourette's is not a specialty of mine, and so I truly don't have an idea of how that would work with Tourette's.
Thank you very much. I think there are no more questions. Last call for questions. Okay, yes. So thank you very much, Dr. Grayson, and thank you to all of you for attending today's webinar. You will receive an email within the hour that will include a link to the evaluation and a link to the recording of the webinar. Please also complete your post-test assessment, which should come up after the presentation should you have requested CE. Please remember that this has been the first presentation, our OCD series. Our next presentation will be on January 11th about treating the family of Dr. Soka and Ms. Lockers. And we will also have a webinar in May on the pharmacology of OCD with Dr. Sable. We hope we will also see you at the Anxiety and Depression Conference next year from April 5th to 8th in Washington, D.C. Again, thank you to all, and special thanks to Dr. Grayson. Bye-bye.
Right. So, I'm not clear from that.